can see your screen. Great, thank you.
Can you hear me?
Yeah, we can hear you now. Yeah.
Excellent. Okay. My name is Anu. I'm one of the radiologists working in Myers Hospital in Lanarkshire. I have a head and neck interest. Thank you, Jay, for giving me this opportunity to speak here. So we've had nearly a whole day's worth of discussion about complications. I will try to give a very short whistle-stop tour about where radiology sits in postoperative complications. So before I start, I have no conflicts of interest and my imaging courtesies as per below. We will have a very short description about the imaging modalities available for postoperative imaging, types of complications and how it looks like on imaging for us. The complications can either be very short topic, you can finish in 5 slides, just show a couple of collections and some vascular complications. But if you go into the nuances, there is much more to it. The imaging in radiology, head and neck imaging itself is very complex. And if you add post-operative changes to it, it becomes even more difficult. Some of the complex surgeries have more complex findings and complex complications that you have to look out for. I'm not even going to talk about the classification system. The imaging modalities that we have, there is ultrasound, and I'll talk about ultrasound in detail when we talk about collections. There is obviously CT, which is a workhorse of imaging, and it gives not only the 3D appreciation of the surgical site, but also other clinical conditions that can happen at the same time. We've had a previous discussion where somebody talked about somebody having a gallbladder perforation. So things like that is very common, or maybe not quite as common as you would want it to be, or we would think, but it certainly happens that just because they've had a head and neck surgery doesn't mean that they cannot have a subacute bowel obstruction or a stroke or, you know, any of these things. So CT can be used safely in those conditions, and you can get a very fast turnaround. MRI also can be used, but immediate postoperative period, you have to be a little bit careful because you need to be safe for the patient to be put into MRI. Fluoroscopy can be used for assessing leaks and fistulas. Nuclear medicine can also be used. There is critical use for its in chylothorax and assessment of that. Some of the complications itself, medical, and I'm not even going to touch that. Some is metabolic, cardiac, pulmonary complications, including P, can be assessed with CT. Now, surgical immediate complications we don't even see in radiology because as surgeons, you see it, you assess it, and it's sorted. But the slightly later ones, which goes from days to weeks, to maybe months, and maybe even after years, those are the ones that we tend to see. Flap complications need an entirely different chat to talk about flaps because it's so complex. Special mention about skull-base surgery. Skull-base surgery, because it is at the skull base, there is involvement of the intraparenchymal, the brain, the meninges, and that would include assessment with MR or CT. You can have CSF leaks. Again, I've shown 2 pictures. You can see in the one of the axial sequences, there is intense enhancement of the meninges, and on the coronal sequence, there is enhancement of the cerebral parenchyma, the cortex, particularly with enhancement of the meninges. So cerebritis and things like that can only be picked with any degree of certainty in MR. So that is where you would think about using MR and having a discussion with the radiologist. See, as a patient safe for MR, can we do it? Can the patient lie still for at least 3 to 5 minutes? So let's start talking about collections. Now, collections can be a hematoma, which is starting to organize. It can be a walled-off or a non-walled-off collection. It can be a seroma. It can be starting to get infected, have become an abscess. What are the clinical features? I don't need to tell you what the clinical features are. You know what it is. It's going to be swelling. It may be inflamed, infected. Clinically, you will have an index of suspicion of what you think it is. But if we go to the imaging modalities available for looking at that, if you think it is a contained collection or a hematoma, patient is too unwell to come down to CT, you could think about doing an ultrasound scan. Now, these are two ultrasound scans. The one on the right of the screen is a seroma, that is skin, subcutaneous tissue, and a anechoic structure, well defined. Posterior acoustic enhancement, that is, there is brightness behind the lesion and there is no vascularity inside. If you put a needle into it, you will be draining kind of serous sanguineous, maybe straw-colored fluid. And if you have a friendly radiologist, they may put a needle in while they're doing the procedure. It's very safe. You can see what you're doing and you can nearly drain it to completion. There is no saying that they can't recollect. It may or may not recollect. But to the right of your screen, you have something which is well defined, but it's got internal septation. It's got bright bits inside. It's certainly got no vascularity when you put the color on. There is still posterior acoustic enhancement. And if you put a needle into that, you may not get anything back because it is an organized hematoma. In which case, it can either resolve on its own or it may need evacuated depending on how big it is. But the problems with ultrasound is you can only look at the superficial aspect. If you want to know what the deep aspects are, you have to look at CT, which gives you a three-dimensional view. For example, if you look at the left of the screen, you can see that there is a collection at the mandibular surgery, and there was an osseous flap. There is a little bit of a collection there, but you can see this collection extending posteriorly as well. And because the normal fat planes and the normal planes are all destroyed or intentionally destroyed during surgery, the infection can go anywhere if there is an infection. So you have to think about where it goes before you can think about, does it need draining? Can it be drained safely? And so on and so forth. So CT is probably a better tool that will answer a lot more questions than a specific question of is there collection or is there a vascular compromise. Vascular compromise. Now, you can either have a vascular pathology relating to the surgery, but that is usually picked up by the surgeons during the surgery or immediate postoperative period. It does not reach the radiologist. Yes, sometimes patients have long lines put in and they may have thrombus or occlusions, and you'll have problems aspirating or flushing it, but those can be answered with an ultrasound scan if it's in the periphery, or if it's a long line with the tip in the SVC, then you'll have to think about getting a CT scan. But if there is a flap pedicle or a flap with a vascular compromise, again, I think it is more a clinical diagnosis of what you think it is. Is it an arterial or a venous insufficiency? And you can always get a CT to see if there is a vascular pedicular thrombus. As you can see in this case, there is a filling defect in the pedicle itself. And you can see at the bottom of that, you can see tiny kind of bright flecks. Those are the surgical staples or sutures or whatever it is that you use. And there's certainly a filling defect, so you know there's a thrombus. And this is another CT scan, a coronal image, and where the arrow points is a filling defect, filling the IJV, and you can see that it's the filling defect that's going quite a long length of it. And if there's any aneurysmal dilatation, you will be able to see that also in CT. So CT is an excellent modality. The next complication we'll talk about is post-laryngectomy leaks of ergocutaneous fistulas. Again, everything is driven by clinical history and your level of suspicion. Radiology in isolation rarely works. It's almost like saying what is gray and looks big, and give an animal's name. You can either say whale or a elephant, but how are you supposed to know what is what? So you need the clinical history to put everything in perspective. Usually it used to be, you can correct me if I'm wrong, that you would do a water-soluble swallow at 7 days to see if the anastomosis held. Now, clinical features, again, I'm not going to teach you how to assess patients clinically, but let me go to the picture. So the picture on the left, which looks like an X-ray, is a water-soluble contrast swallow. Patient's sagittal, so it's taken from the lateral aspect. You can see the contrast in the mouth, in the oropharynx, and you can see some going along to the esophagus, and there is a tiny divot of contrast going anteriorly, and the arrow points to a little puddle of contrast where you would normally expect vallecula. So when the patient was asked to take a couple of dry swallows to see that if it cleared, it did not clear. It remained as a residual pool of contrast. Now, this is the area where you've stapled the tongue base, and that is, you know, there is a little bit of tension to the sutures. And I am told that that is where there is a redundant mucosa as well. So how do we know that this is not contrast in the redundant mucosa that you have left there purposefully, or is it a tiny little leak? It's very difficult to say with any degree of certainty that this is not a leak. So you will probably get really annoyed with us giving a report saying a leak cannot be ruled out. It may be, but if it is a leak, time will tell. Time will out this, and it will become what is seen on the next slide. Usually, even if it's a redundant mucosa, a couple of dry swallows should get it empty completely. If it doesn't empty completely, there is maybe way too much mucosa which is holding on to contrast. And if you have way too much mucosa holding on to contrast, does that mean that then you have a potential for leakage there, because that is where things will collect? Is it a place where a diverticulum can form? That's a discussion for another day. But in the next image, you can see it's a sagittal post-contrast CT. You can see an air fluid filled collection in the anterior aspect, and the arrow points to that. And this is what a leak looks like. It becomes slightly bigger over time. And you can obviously see where the laryngectomy has happened. There is a speaking valve. You can see the air in the esophagus posteriorly. So this patient unfortunately went on to have this fistula where he had contrast leaking into the tracheobronchial tree, and you can see the contrast in the tracheobronchial tree. He was managed without any surgeries and conservatively, and I believe that he completely recovered and everything went back to normal for him. But this is how a presentation of leak and a fistula usually looks like, and it can be difficult to assess only on the basis of radiology. Sometimes you may have to redo the test again. Now we are going to go to flaps. Jay, you have to tell me if I'm going over time. I can always cut short.
2 minutes.
2 minutes. Okay, that'll stop. So there are different types of flaps. There is osteocutaneous flap and myo and fasciocutaneous flaps. Complications can be because of complications at the donor site, complications at where it's been inlaid, complications specific to flap itself, which can be collections, pedicles, pedicle thrombus, as I've spoken before, fistulas, recurrences, metalwork extrusions, non-union of the osseous flap. Delayed complications can be recurrences. You can have second primaries. You can have sarcomas, osteoradionecrosis if it's been a radiotherapized field. How does a flap look like on CT? Now, an osteocutaneous flap will have all the characteristics of bone, which will be bright on CT, and will have the similar characteristic of bone on MR. And as you can see, the bottom one is an osteocutaneous flap. Now, if you look at a myo or a fasciocutaneous flap, it will have fat in it. So it will have all the characteristic of fat, which would be gray on CT, bright on T1 and T2. Let's go to the next one. Bright on T1 and T2 and completely suppress on STIR. So STIR is a fat suppression sequence, so it will suppress completely on STIR. But if you see any enhancement where the flap has been stitched to the native tissue, that is where you would expect recurrence. So soft tissue enhancement, that is what recurrence looks like. And it has to be considered recurrence unless proven otherwise. The different types of flaps will not even go there. Complications. So again, collections always look like low attenuation, flecks of gas in it. It may or may not have flecks of gas. You see flecks of gas, it's either having a connection to the skin or it's got gas forming organisms in it. If there is no connection to the skin or the hollow viscera and it's got gas in it, it is proven infectious. It is infectious unless proven otherwise. Then you can obviously have displacements and non-union of the osseous flap. You would not want to see that. Now, the one at the extreme right is a coronal sequence of this is somebody who had a maxillary malignancy, had a free flap. And as you can see, there is the nasolacrimal apparatus. It opens from the medial aspect of the orbit, runs along the lateral wall of the nose, and opens out into in the inferior meatus. So this is either obstructed or maybe even obliterated. Can't say with any degree of certainty, but what has happened is there is an upstream dilatation and a prominence. A patient presented with swelling, so that they had ductal cystitis, probably due to pressure effect. Collections always look like collections. They are low attenuating lesions. If you put a Hounsfield unit, the circular thing that you can use in CT, it'll give usually fluid attenuation. Okay. Medical thrombus, we have looked at before. Metal extrusions may present longer, much later, and it can present as a lump under the skin, which makes you think, is it recurrence? And you do a CT, and if you see a little stone, a screw that is sticking out the way, you know it's not recurrence. There's no soft tissue. It's only just metal extrusions. It can happen, but sometimes it can erode through the skin, which is maybe not quite as nice. We've had discussions about chyle leak in the morning. Chyle leak looks like pleural effusions for us on CT. So it is a clinical diagnosis, aspiration, but again, it was, as was said in the morning, it can be whitish fluid, milky fluid, or it can be serous fluid. So you have to send it for laboratory examinations. Now, there is, in theory, a nuclear medicine study that you can do. It is a technetium 99 antimony colloid SPECT CT, but it's highly specialized, and I don't know how available or how readily available it is. In theory, in the right hands, it can be embolized. If you remember the anatomy, which is in the previous slide, but I will not go into that, there is the sternochyly. It is at posterior to the crux of the diaphragm. It can be cannulated, and an interventional radiologist trained in that may be able to throw off coils. I have read this in books. I have never seen it. Vocal cord palsy, you can identify it looking at it. We have our ways of identifying it. I don't know if there are any radiologists here because we can't see movement. We can only look at secondary signs, and the secondary signs would be adduction of the adduction and medial rotation of the array epiglottic folds, as you can see in the middle picture, and that makes the piriform fossa very big. You can see a paramidline vocal cord. The contralateral or the normal cord kind of bulges a little bit to make up for it, and the laryngeal vestibule is a little bit bigger. So these are kind of secondary signs that we think is sign of vocal cord palsy, but it's very easy for you guys. You just need to look down. If it's not moving, it's not moving. Delayed complications, we have touched upon recurrence. You know what recurrence looks like. It is an unnatural enhancement. Sarcomas have a very specific look. And they usually at the radiotherapized field, and again, high index of suspicion is what drives the diagnosis of sarcoma. Osteoradionecrosis is very important. We may need to do CT and MR to diagnose or even make a diagnosis of osteoradionecrosis. If there's cortical disruption, trabecular interrupted fractures, may or may not have soft tissue, but usually there's this collection. It's almost like sometimes it can come with infection, osteomyelitis, and then you can have a little bit of collection around it. But MR is more, and also be helpful. I think both should be used in conjunction, CT and MR. I think I will stop now. That was very fast.
It's very good. Thank you very much. I think I have to stop here. We are well into the coffee. It's not your fault. It's a cumulative delay. So we'll take a 10-minute short break and we'll be back.
Okay.